consolidation for the morning. What I would like to do is just get one little mini lecture underneath our belt, and then we'll go back over the day's bits and bobs. Okay. I'm conscious to try and break up each little mini lecture now with things in between, because you'll be fatiguing and I'll be fatiguing. So if you open your book to page 7, which is celiac disease. Now, there's a bit of a pattern now forming with conditions that fit under the guise of gastroenterology, that all of them give you increased rates of gastric cancer, bar inflammatory bowel disease. Celiac disease really is no exception, apart from that it's worth noting that there are some other quite well-known cancers that it's associated with. And we've already said esophageal cancer, that middle third, squamous cell esophageal cancer, is increased in celiac disease. We talked about in H. pylori that you got malt cell lymphoma of the bowel that was cured with giving PPI therapy, amoxicillin and clarithromycin. And the cancers that are associated with celiac disease are squamous cell carcinoma of the esophagus, gastric, T-cell small bowel lymphoma, so we've now got 4 different types of lymphoma and subtypes that we're aware of. You've got malt cell lymphoma that we know how to cure with our triple therapy. We've got T-cell small bowel lymphoma. Now, all of the other lymphomas that we talked about earlier were B-cell lymphomas, so about B cells. This is about T cells. Remember, we had lymphocytes, and there were B and T lymphocytes. These went off to the thymus. B cells, most of the lymphomas are about B cells. This is T-cell small bowel lymphoma. We had Hodgkin's lymphoma and non-Hodgkin's lymphoma. We divided Hodgkin's lymphoma up into 3 different types: lymphocyte predominant, lymphocytic depleted, and nodular sclerosing. We divided our non-Hodgkin's lymphoma into high-grade and low-grade lymphoma. Out of the 2, I don't know which one I'll prefer to have, because if you couldn't cure me with my high-grade, then I'm going to die pretty quickly. Whereas at least if I had the low-grade and it was incurable, at least I had a reasonable amount of prognosis no matter what happened. So squamous cell of the esophagus, gastric cancer, T-cell small bowel lymphoma. Now, the reason that they like asking questions about celiac disease is it all boils down to questions about subtotal villous atrophy. That when you have a look into the duodenum and into the small bowel, those tiny little projections that are down the bowel that are all involved with absorbing all of the goodness, those get eroded away, and that's subtotal villous atrophy, where you only get much smaller sections because the tops have been taken off. It's a total villous atrophy, which is almost smooth. Now, the reason that celiac disease results in lymphoma of the bowel is that you've got a chronic inflammatory process that's going on, enough to shear the tops of these villi off, and that continues onwards, and you've got lymphocytes that are protecting you from nastiness coming through here. And if there's chronic inflammation with cells, and eventually you're probably going to get a cancerous change. And that's usually T-cell small bowel lymphoma. But there are lots of other things that give you the picture of subtotal and total villous atrophy. There are lots of other conditions. And they are strangely interrelated. So let's talk about some of those conditions. I break them up into non-infectious and infectious. So in my non-infectious causes, I've got celiac disease, which is where you have an allergy, so you build up an immune response to the gliadin fragment and gluten, so it's really considered a gluten sensitivity. When you eat a gluten diet, gluten gets coated, it coats your villi, And in combination with the gluten and proteins that are within the villi wall, there's an immune reaction which shear these off and destroy them. So celiac disease causes subtotal villous atrophy that way. You can also get subtotal villous atrophy from IgA deficiency. So you can be born with IgA deficiency. You can also get hypogammaglobulinemia, low levels of immunoglobulins, which is IgA, including all of the others, from anything. Where do immunoglobulins come from? Well, we had our lymphocytes, we had our B cells, those turned into plasma cells, and plasma cells ended up making immunoglobulins of different varieties. So if you have some badness that goes on with B cells or plasma cells, eventually you may end up with low levels or monoclonal bands or high levels where you shouldn't have them, but there's something disrupted with the levels of immunoglobulins that you have. So that can occur in lymphoma, chronic lymphocytic leukemia, also in myeloma, because we said myeloma was a malignant proliferation of plasma cells. So what you end up with when you do your plasma electrophoresis is you get a big monoclonal band, and then you get small other bands. So you get deficiency of other types. One big band, which is all the same and useless. There's no point in going to your toolbox, and your toolbox is filled with tools that are all exactly the same. You want a selection of different tools to use to fight infections, and all of these are subdued. Or you can be born with an IgA deficiency. Now, IgA, you may remember from reading them before, protects mucosal surfaces. That's the job of IgA. And if you imagine in your bowel, if you're deficient of IgA, you can't really protect the mucosal surface of your small bowel from pathogens that might be around. And if you can't protect them very well, you end up getting infections and inflammation along here that ends up damaging and causing subtotal villous atrophy. That's why IgA causes subtotal villous atrophy. Another non-infectious cause of subtotal villous atrophy is small bowel lymphoma. Now, although all of these individually can cause subtotal villous atrophy, what I find quite interesting is celiac disease is associated with IgA deficiency, and also celiac disease can cause small bowel lymphoma. So not only are they independently associated with subtotal villous atrophy, but celiac disease is also itself associated with IgA deficiency and small bowel lymphoma. Sometimes you get a history of somebody with celiac disease, and they have poor absorption. They go through a process of having serological tests done, anti-TTG antibodies. That's what NICE advises. You might have read old books where it talks about anti-endomyocele antibodies or anti-gliadin antibodies, but NICE advises that your first-line serological test is anti-TTG. Their anti-TTG comes back positive. So you say, this person has celiac disease. I know because they're anti-TTG positive. But still, you have to do an endoscopy. Why do you have to do that? That seems pointless. We've got a serological test that is very good at diagnosing it. Now the point is, this is something to do with funding, really. People who have celiac disease get all of their diet paid for by the NHS. They not only get all of their diet paid for, but they get all of the rest of their medications paid for by the NHS as well, for a reason that I can't work out. Now, because there is a big cost demand when somebody gets a diagnosis of celiac disease, we can't just let them off with a serological test. We've got to do an endoscopy. So once you've taken a biopsy and look at it, that's considered the gold standard test. Now, in actual fact, I would argue that TTG is more sensitive than doing their endoscopy. And if you spoke to a gastroenterologist, they would probably agree. But there are some people who will have TTG positive that they'll biopsy, and the biopsy will come back negative. And those people, you don't need to pay for their diet. You don't need to pay for their prescriptions. So TTG should only be used to guide endoscopy, but is probably more sensitive than endoscopy in detecting the disease. In years to come, things will probably change, and what you'll do is you'll do the anti-TTG, and that will be enough to make your diagnosis of celiac disease. But now, is that enough to make your diagnosis? If the question is, can you make a diagnosis of celiac with anti-TTG? No, you need to do an endoscopy. Now, the story might go, I've had celiac disease. I've had malabsorption from my celiac disease. I've stopped eating gluten. I seem to get better, and my diarrhea gets better, and I start putting on weight and feeling better. Then after a number of years, I start getting diarrhea again and start losing weight. That can be one of two reasons that this happens. The first reason, and the much more likely reason, is that they've started eating something that has gluten in it and they don't realize. Now, oats. Oats don't have gluten in. And if you buy oats that are prepared for gluten-free diets, you can eat it without any problem at all. But generally, the same plants that process oats also process lots of other things that end up having gluten in, and the two gets mixed together and it ends up sparking off your celiac disease again. So it has to be in a bag prepared for celiac diet. So they could be eating oats, suddenly change the make of the oats that they buy, and the diarrhea gets worse. So they're probably eating something that has got gliadin and they don't realize. Another possibility is that they could have developed small bowel lymphoma, because celiac disease does predispose you to this. And suddenly you now have started off with subtotal villous atrophy from celiac disease. That's got better, and you've ended up getting small bowel lymphoma and then subtotal villous atrophy from your small bowel lymphoma. And these people aren't infrequently re-OGD just to have a little look and a check. Now, anti-TTG antibodies. Now, we can measure for anti-TTG antibodies, but there are two types of tests. There's IgA anti-TTG, and there's IgG anti-TTG. Now, it sounds a little bit complicated, but all this means is that if you are IgA deficient, which you're not infrequently IgA, it is associated with celiac disease, and you look for IgA anti-TTG, then it's going to come back negative even though you are celiac disease, because you're deficient in IgA antibodies. So if you've got a good clinical suspicion that somebody's got celiac disease and you do the initial anti-TTG antibodies and it comes back negative, then you do plasma electrophoresis to see whether you're actually deficient in IgA. If you are, then you repeat and you do the IgG anti-TTG. You think, well, why not just do this first? That makes sense, doesn't it? This, lots of money. This, nice and cheap. So we do the cheap test. If the cheap test gives us the answer that we're expecting, then that's lovely. If the cheap test doesn't give us the answer, we look for the reason that maybe why it's not giving us the answer. If we find out that they are IgA deficient, because plasma electrophoresis is very cheap as well, we end up doing the expensive test. Now, is that clear, by the way? Now, the infective causes are giardiasis, that's that little parasite thing that people get when they go on holiday and eat dodgy food, sometimes found in institutions as well, mental institutions or institutions for people with learning difficulties, giardiasis. The pattern is people come in and they're losing weight and they have this waxy, fatty stool that floats and won't flush away. So pancreatic disease can cause fatty stools that float, but so also can giardiasis. And the reason why is in pancreatic disease, you're not releasing enzymes that break down fat so you can absorb it. In giardiasis, you've got subtotal villous atrophy and parasites that prevent fat from being absorbed into the body, so you end up pooing it out. So giardiasis. How common is it? Not terribly common. We've probably seen 5 or 6 cases. And then the things that you may see sometime in your lifespan, or if you go to India you might see, is tropical sprue. Tropical sprue, in India it's supposed to be reasonably prevalent. The organism that causes it, nobody's entirely sure. Some think it's Campylobacter, some people think it's E. coli, but nobody's really pinned down the cause of it. All that we do know is when you treat these people with antibiotics, tetracyclines, for a long period of time, they get better. So salmonella is another thing that is suggested, but nobody really knows. It's diagnosed by being in a place that has high prevalence, like India, for a period of at least 2 weeks, preferably a month. When you have signs, and on OGD, you have subtotal villous atrophy, that you're negative for Coeliac's disease, that's probably tropical sprue. And the last one, Whipple's disease. Love asking questions on this. They love it. The reason being is when you take your biopsy, you get PAS positive staining on it, so PAS positive granules. So it's a very characteristic feature. You can also get a pattern, LAD. Lymphadenopathy, arthropathy, diarrhea, and dementia. You treat these people with high-dose tetracyclines for an extended period of time and they get better. The organism is trophi whippeli, or Trophimina whippeli. Arthropathy. How many cases, has anybody here ever seen a case of Whipple's disease? Before anybody puts a hand up, I would scream liar. Because the amount of people who are diagnosed with Whipple's disease, worldwide, last year, 9 people, worldwide. The amount of people diagnosed with this, since 1907, 696 people. So that's less than 10 people a year are diagnosed, worldwide, with Whipple's disease. Yet they love asking questions in the MRCP. It does. It does. But still nobody's ever diagnosed. So whenever anybody ever comes up with it as a possible diagnosis for somebody, you can chuckle to yourself. Or you can get yourself, if it turns out to be Whipple's disease, then try and publish it as quickly as possible. But case studies are very few and far between. You end up, when you take biopsies and you have a look at their bowel is just packed with this waxy, fatty, lymphocytic infiltrate throughout their whole bowel, which prevents absorption. Then you get that organism that goes on the rampage around the body and affects the brain and joints and other things as well. So it's not a particularly pleasant thing, but with the way that we throw antibiotics around these days, I think that it kind of die out and we'll never see it. Now, if you're not absorbing fat properly because you have subtotal villous atrophy from either a non-infective cause or an infective cause, you're also not going to absorb your fat-soluble vitamins. And your fat-soluble vitamins was DEEK, just reminding you. D, low vitamin D, osteomalacia, rickets, osteomalacia. Now we know not only can be caused by vitamin D deficiency, it can be also caused by Fanconi syndrome as well, associated with a proximal myopathy, looser zones in the bones. Vitamin K, the clotting factors to do with vitamin K, 1972. And the other things that aren't absorbed very well in the small bowel, the second part of the small bowel, are iron, folate. Folate malabsorption is much more common, folate decrease is much more common than B12 being decreased. And also you don't absorb calcium very well. Now you can see that not only are you low in vitamin D, but you're also low in calcium as well. So that's going to push your osteomalacia and make that even worse as well. If you're predominantly iron deficient, you're going to end up with a microcytosis. If you're predominantly folate or B12, then you're going to be have macrocytosis. If you've got deficient in both of them, you can end up with something called a diamorphic blood film, where you end up with some big red blood cells, some small blood cells. And your computer, you stick it through, it counts and it looks at the size of this, then it looks at the size of this, it looks at the size of this, and it puts them into numbers. And it works out the average. And when it works out the average, it gives you 91. My MCV is 91. That looks normal to me. Because some of them you've got MCVs of 107 and some of them you've got MCVs of 70. If you average it all out, you might end up with a normal MCV when you've got a diamorphic blood film, when you're both B12 and folate and iron deficient. So your INR is going to be elevated. You're going to be anemic. This bottom left-hand box are the things that you are okay in celiac's diet and avoid in celiac's diet. If you look on the left-hand side, wheat, barley, rye, make lots of breads out of those. On the right-hand side, maize, oats and rice. Sometimes, I mean, there's loads of other things that you can eat in celiac disease, but often confusing is that, can I eat that or can I not? So I've put those in the okay in celiac disease. We talked about this a minute ago. Tissue transglutamase, TTG, anti-TTG, that was advised by NICE as the first line, but you may have seen anti-endomyocel. That used to be the gold standard, but it's nowhere near as good as TTG. Still done in some hospitals because it's even cheaper than doing the TTG. So if we go for the take-home points, serological testing for celiac disease only directs endoscopy, it doesn't replace it. Direct complications of celiac disease are secondary to vitamin, that's fat-soluble vitamins, calcium, iron and folate, and that's occasionally accompanied by B12, malabsorption. Whipple's disease is a triad of arthropathy, lymphadenopathy and subtotal villous atrophy. You can also get dementia with it as well, and a long list of other things that as long as your arm, but you'll never see anybody with it. Remember the PAS-positive granules, tetracyclines that you treat people with to get better. Same with tropical sprue. The last box that I'd like you to draw your attention to is this bit on the right here, associated with celiac disease. Like Graves' disease or myasthenia gravis or rheumatoid arthritis or any of the autoimmune conditions, are all related to each other. So if you've got celiac disease, you're going to be predisposed to other autoimmune conditions. Your classic HLA subtypes that people link together. Dermatitis herpetiformis. If you get a rash on the buttocks, that's dermatitis herpetiformis. In your exam, rash on the buttocks equals dermatitis herpetiformis equals celiac disease. Almost pathognomic of celiac disease. That's a pair of buttocks, by the way. You're frowning a little bit there. Okay. We've talked about IgA deficiency that celiac disease is associated with. Also small bowel lymphoma, gastric cancer, esophageal squamous cell carcinoma. That's why I put it into the GI malignancy bracket. And just thinking back, do you remember when we were talking about prophylaxis for splenectomy? We said either you could have your spleen whipped out on purpose or by mistake. You could have sickle cell disease that would infarct your spleen, but you could also end up with hyposplenism from celiac disease, from the autoimmune splenectomy. It's called autosplenectomy. Your body just destroys it. What are you going to give them? You're going to give them 5-yearly pneumococcal vaccine, Hib, Haemophilus influenza B, meningococcal C, and then you're going to give antibiotics every day, which is either Pen V or erythromycin. So we go for the question. A patient presents with a long history of diarrhea, abdominal distension, and weakness. What do you think I'm kind of suggesting with the weakness there? Proximal myopathy, that's what I'm going for. Proximal myopathy is associated with any endocrine excess and also with osteomalacia, which can be due to vitamin D, also can be due to Fanconi syndrome. He also complains of an itchy, blistering rash on his buttocks. By now, you should have what the diagnosis is. That equals dermatitis herpetiformis, equals celiac disease, so it's pathognomic of the condition. His blood results show a low calcium concentration and phosphate levels when a blood film was examined, and his red blood cells were found to contain Hal Jolly bodies, the marker of hyposplenism. Which of the following statements concerning this patient's disease is not true? So if the little stem is true, then that's not the answer we're looking for. Low IgA levels are often found. That's true, low IgA, which is why sometimes our serological tests don't work. We would then do plasma electrophoresis. If that showed the IgA deficiency, we would then do an IgG-based serological test. Since the advent of serological testing, endoscopy is not performed for diagnosis. That's not true. So that's the answer we're looking for. If we just go through the remaining, malabsorption causes a variety of complications other than weight loss, yes. Fat-soluble vitamins, iron, folate, B12. An increase in GI malignancy is well recognized, yes. Squamous cell carcinoma of the esophagus, gastric cancer, T-cell small bowel lymphoma. Oats need not be avoided, that's true. It's in the bottom left-hand box. Maize, oats and rice. Wheat, barley and rye, can't eat.